So I'll be presenting a case of sympathetic ophthalmia, grave concern. Sympathetic ophthalmia is a bilateral diffuse granulomatous intraocular inflammation that occurs after surgery or penetrating trauma to one eye in most of the cases. It's usually due to a cell-mediated immune response, which is against the ocular self-antigens found on the photoreceptors, retinal pigment epithelium, and choroidal melanocytes. It occurs usually more so after non-surgical trauma. So we come across a 20-year-old patient who presented with the complaints of dimness of vision in the right eye since the last 7 to 10 days, which was gradually progressive in nature and associated with pain and redness. He had a history of perforating injury to the left eye 2 years back, following which he consulted elsewhere, and he was diagnosed with a superior sclerocorneal tear with iris prolapse along with hypopyon in the left eye. He underwent repair for the same, and he was prescribed oral steroids. However, he had minimal improvement of vision post-surgery, and this again reduced after 1 month. He had no significant comorbidities and no significant drug allergies. As you can see in both eyes, the vision was very poor. There was evidence of anterior segment inflammation. And in the left eye, there were two sutures which were seen superiorly at the site of the previous repair. In both eyes, the media was hazy. The optic disc was hyperemic and margins were blurred, and there was evidence of exudative retinal detachment. As you can see from the USG, there is choroidal thickening as well as exudative retinal detachment. The OCT in the right eye was suggestive of dry fovea, but there was a disorganization of the inner retinal layers, whereas the left eye, there was subretinal fluid present with a choroidal hypertransmission. The fluorescent angiography did show disc leakage. The other details were not very clear due to a hazy view. So we started him on the topical steroids, and he was advised for IVMP 1 gram for 3 consecutive days, followed by a course of oral steroids at the dose of 1 milligram per kg per day, with a weekly tapering by 10 milligram, along with a tablet azathioprine 50 milligram thrice a day for 1 month, with a monthly tapering dose. He was symptomatically better, and the fundus was suggestive of right eye resolved bullous RD, and left eye subretinal fluid still persisted. He was followed up monthly. Eventually, the fundus did show scarring of macula. The vision did improve in the right eye to 6/9, and in the left eye, it was 6/18. So our provisional diagnosis in this case was sympathetic ophthalmia. This was due to the presentation. There was also a history of penetrating ocular trauma and presence of bilateral granulomatous panuveitis. So the clinical implication lies in the fact that this needs to be differentiated from VKH. VKH tends to happen more in females, and also there is associated neurological systemic auditory manifestations which take place. Also, it has got a particular prevalence in Hispanics and Japanese. Also, I wanted to note on the importance of enucleation versus evisceration. Evisceration is sometimes more cosmetically acceptable for the patient, although the presence of remnant uveal tissue does predispose to secondary malignancies, which may take place and might itself cause sympathetic ophthalmitis. So the unique feature in my case was that the duration after surgery, it was found to be 2 years, whereas usually we see that 80% of the cases when this is reported, it's usually within 3 months of injury, and 90% within 1 year. So the take-home message was that sympathetic ophthalmitis, usually it's a clinical diagnosis, although we do need ancillary investigations to confirm the same. The mainstay of treatment is usually systemic immunomodulatory therapy, again, IVMP for 3 days followed by oral steroids, and then also we need to add immunomodulators or biologics if needed.
How long will be the treatment, immunosuppression?
We'll have to maintain it.
How long? Maintenance phase?
Sir, actually, your case wonderfully diagnosed, wonderfully managed. Only issue is that you are tapering your steroids almost like you would be tapering antibiotic steroid eye drops after cataract surgery, 4 weeks, 6 weeks. That is not the way to be. In all these severe autoimmune conditions, you have to give it for at least 1 or 2 years. And you please understand one concept, that you give immunosuppressives. Why? Because as a steroid sparing therapy, all these immunosuppressors will take 2 to 3 months to build up action. Okay. And till that time, you have to give steroids. Right, so for example, you have written that I have given IVMP and then done a 10 milligram taper. So that doesn't build up concept. Your concept has to be that you have to give suppress the immunity. So either you give the steroids in immunosuppressive dose or you start giving non-steroidal immunosuppressants. Non-steroidal immunosuppressants will take up 2 to 3 months to build up the action. So you have to give steroids for at least 3 months, and then once you think that there is no recurrence of disease, you start at the tapering at the rate of 10% therapy per week.
What are the biomarkers you use to see for resolution of VKH? How did you say the VKH resolved? Just the vision? What are the, you didn't show any other parameters?
We can do something called the choroidal vascularity.
No.
What did you do?
Subretinal
How did you
presence
know
of-
that the patient is in resolution? Did you do OCT? Did you do a FA?
Presence of subretinal fluid,
One.
whether the bullous RD is resolving
So
or
one, I like to say, one biomarker is OCT, right? So did the serous detachment settle?
it's settled.
Does FA show subclinical lesions? Did you do a FA? No. Follow-up FA is not there. And you may see of the lesions on ICG but FA. So finally, to be free,
You have
either
to
you
follow
do an
up
ICG to be free or you give it for 2 years and then start to think of tapering.
Okay.
So I've been telling everybody tapering azathioprine at 1 month, tapering steroid in 3 months. You need to say what are the biomarkers. The biomarker is one is OCT, second biomarker is FA, and the third biomarker in VKH is ICG, where you have to be negative. Or you can check for choroidal thickening. So choroidal vascularity is not the indication. So whenever you see uveitis, learn about the biomarkers which need to be resolved before you start to taper. Okay, thank you.
Thank you.
I think Neha